Hi everyone, in this video, I will talk about atrial flutter. Atrial flutter is an abnormal cardiac rhythm characterized by rapid, regular atrial depolarizations at a characteristic rate of approximately 300 beats per minute. Atrial flutter is characterized by a large re-entry circuit, usually within the right atrium encircling the tricuspid annulus. The risk of atrial flutter increases with age. The atrial rate is approximately 300 beats per minute, and is usually associated with 2:1, 3:1, or 4:1 AV block. There are two types of atrial flutter. Type 1 flutter, also known as typical atrial flutter, and Type 2 flutter, also known as atypical atrial flutter. The designation of typical atrial flutter involves a macro reentrant circuit traversing the cavo-tricuspid isthmus (CTI). This isthmus is the region of right atrial tissue between the orifice of the inferior vena cava and the tricuspid valve annulus. If this isthmus is involved, it is called typical atrial flutter or CTI-dependent atrial flutter. The circuit is usually a counterclockwise rotation around the tricuspid valve, exhibiting a classic sawtooth appearance in the inferior electrocardiogram, ECG, leads, 2, 3, and AVF. This diagram shows the position of cavo-tricuspid isthmus. If the CTI is not involved in the underlying mechanism, then it is called atypical atrial flutter. This type of flutter can involve any region of the right or left atria, around areas of scar tissue due to intrinsic heart disease or surgical/ablated scar tissue. The risk factors for atrial flutter are post-cardiac surgery, previous myocardial infarction, ischemia, fibrosis, heart failure, after antiarrhythmic drug initiation, obstructive sleep apnea, high blood pressure. The risk factors for atrial flutter are heart failure, thromboembolic events, atrial fibrillation. The sign and symptoms of atrial flutter are palpitations, tachycardia, fatigue, discomfort in chest. The ECG shows regular, narrow QRS complexes. Flutter waves, which are a sawtooth pattern of atrial activation, most prominent in leads 2, 3, AVF and V1. As the underlying atrial rate is often around 300 per minute, the ventricular or heart rate is dependent on the degree of AV block. For example, if there is 2:1 block, the ventricular rate will be 150 per minute. Atrial flutter should always be suspected when there is a narrow complex tachycardia of 150 beats per minute. Carotid sinus pressure or intravenous adenosine may help to establish the diagnosis by temporarily increasing the degree of AV block and revealing flutter waves. This diagram shows the sawtooth appearance on ECG. Medical management with digoxin, beta blockers, or verapamil is often successful in controlling the ventricular rate. Electrical cardioversion, to restore sinus rhythm. Following cardioversion, beta blockers or amiodarone can be used to prevent recurrent episodes of atrial flutter. Radiofrequency catheter ablation, cavo-tricuspid isthmus no longer able to carry electrical signal, so prevents re-entry. Anticoagulants, reduce chance of clot formation. Class 1C antiarrhythmic drugs such as flecainide are contraindicated because there is a risk of slowing the flutter circuit, facilitating 1:1 AV nodal conduction and producing a paradoxical extreme tachycardia and hemodynamic compromise. Thank you for watching. For more videos like these, follow us on YouTube.